Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Rituximab Purging and/or Maintenance in patients receiving an autologous transplant for relapsed follicular lymphoma, a prospective randomized trial from the Lymphoma Working Party of the European Group for Blood and Marrow Transplantation, by Ruth Pettengill and co-workers. My name is Michele Ghielmini, and I'm Medical Director and Head of Medical Oncology at the Oncology Institute of Southern Switzerland in Bellinzona. My oncology specialty is lymphoma and autologous transplant. The study was designed in the 90s when rituximab was not yet routinely given to all patients with follicular lymphoma. Therefore, the inclusion criteria selected only rituximab-naive patients with relapsed follicular lymphoma who had responded very good to an induction chemotherapy. They were all to receive high-dose chemotherapy according to the beam conditioning regimen, followed by autologous stem cell rescue. The study was designed with a 2x2 factorial design in order to answer the following two questions. First question, does rituximab have a role as an in vivo purging agent? Second question, is rituximab maintenance after high-dose chemotherapy safe and effective? Half of the patients were assigned to receive in vivo purging as a weekly infusion of rituximab every week for 4 weeks, given after the induction chemotherapy and before stem cell collection. Half of the patients were also randomized after transplantation to receive or not maintenance rituximab, given in the form of one infusion of rituximab every 2 months for 4 times. Originally, the study planned to enroll 480 patients, but due to the increasing difficulty to find rituximab-naive patients, the study was finally closed after having included 280 patients only. Of these, 200 were transplanted. In conclusion, 4 groups of approximately 50 patients each were treated. The first group received both purging and maintenance, the second group purging only, the third group maintenance only, and the fourth group neither purging nor maintenance. The endpoint for both questions was progression-free survival. To partially compensate for the reduction in statistical significance due to the lower as planned number of included patients, these were followed for a long time until the originally planned number of events was reached. Therefore, the median follow-up time is approximately 8 years. The main results of the study are that, first, in vivo purging with rituximab does not influence progression-free survival, but does also not increase the toxicity of transplant nor delay hematological recovery post-transplant. Second, rituximab maintenance significantly prolongs progression-free survival, and in the multivariate analysis is the only factor remaining significant for PFS. Third, when the 4 groups are compared to one another, we see that the longer the rituximab exposure, the longer the PFS. Fourth, the overall survival does not differ between groups. And finally, it appears from the study that rituximab maintenance does not increase toxicity. Which are the clinical consequences of this trial? Strictly speaking, these data refer to a population which, in developed countries, does not exist anymore. Patients with follicular lymphoma in remission after a therapy not containing rituximab. Nevertheless, there are several practical consequences of these trial results. First, we now know that in vivo purging should not be part of standard transplant protocols for follicular lymphoma. And this is even more true today, when the potential in vivo purging effect is taken care of by the rituximab already included in the induction chemoimmunotherapy. We know that rituximab remains in the patient's blood for many weeks, and therefore it can exercise the purging effect before stem cell collection. Secondly, rituximab maintenance has already shown in other studies to prolong the PFS after chemotherapy and rituximab, and after rituximab alone, so it is no surprise that it does prolong PFS also after high-dose chemotherapy. Third, the good news is that rituximab maintenance after transplant does not increase toxicity, as this could have been expected in this population of already heavily immunosuppressed patients. Finally, because it does not impact on overall survival, the decision to give or not rituximab maintenance after high-dose chemotherapy will finally depend on the cost-benefit evaluation between a longer progression-free survival and higher financial costs. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.